going to get started.
I don't want to say that one. That Moriarty and...
Good morning and welcome to, I don't remember what day it is, but it is Friday of our budget hearings. Today we are, this morning we're glad to be joined by Secretary of the Department of Health, Secretary of the Department of Drug and Alcohol Programs. We will continue as we've done all week with members getting 5 minutes apiece to ask questions. On the table, in the middle of the table, is our timekeeper. When it is green, that means that our members will commence with their comments. Yellow means that there are 30 seconds left, and red means that we would like folks to stop and wrap their comments up. Before we begin, Chairman Struzzi, do you have any opening comments?
Yes, thank you, Chairman Harris. Good morning, everyone. Thank you for being here. I know we have a lot of important questions to ask. Clearly, health and drug and alcohol programs are very important as we face a lot of increasing mental health issues, substance abuse issues. So we look forward to hearing your testimony, and obviously this is about the budget, so we want to hear about the numbers too. So thank you.
We thank the chairman, secretaries. If you would please introduce who is at the table with you. After you introduce who's at the table, we will swear everyone in, and then we will begin with our hearing.
Wonderful. Dr. Deborah Bogan, Secretary of Health, and I'm here with the Executive Deputy Secretary, Kristen Rodak.
Thank you.
Good morning. I have with me Kelly Primus. She's our Deputy Secretary, and I have Erica Noko, who is the Bureau Director of Program Oversight.
Will everyone who's testifying please stand so we can swear you in? Do you solemnly swear that the testimony you're about to give is the truth, the whole truth, so help you God?
I do.
Thank you so much. You may be seated. Either Secretary, if you want, you can do an opening statement. If not, you don't have to, and we can jump right into questions.
I do have a
Okay, absolutely.
Wonderful. I'm going to go first. Good morning, Chairman Harris, Chairman Struzzi, and members of the House Appropriations Committee. Thank you for this opportunity to appear before you to discuss the proposed 2025-2026 fiscal year budget for the Department of Health. This budget proposal continues to support the department in its mission to promote healthy behaviors, prevent injury and disease, and to assure access to quality health care for all Pennsylvanians. Last year, with investments made by the General Assembly, we were able to, among other things, support regional maternal health coalitions to improve care for mothers and babies. Continue support for EMS providers, including funding summer camps for high school students to explore EMS careers. Invest $3 million in schools to ensure students have access to free menstrual hygiene products so they can focus on learning, and continue to provide naloxone leave-behind kits, 27,000 over the past 2 years. The proposed 25-26 budget will allow the department to continue focusing on improvements in many areas of public health and safety, including improving maternal health, focusing on postpartum depression, enhancing care for older Pennsylvanians, strengthening the healthcare workforce, especially behavioral health and rural areas, and leading the charge on neurodegenerative research. I look forward to working with all of you to help implement this sound budget proposal that would enhance the health and well-being of all Pennsylvanians. And I'm happy to answer any questions you may have, but first I'm going to turn the microphone over to my colleague, Dr. Latika Davis-Jones.
Thank you. Good morning. Thank you, Chairman Harris, Chairman Struzzi, and the distinguished members of the House Appropriations Committee for the opportunity to be here today. With me, as I already mentioned, is Kelly Primus, our Deputy Secretary, along with Erica Noko, the Director of the Bureau that oversees all of our drug and alcohol and gambling programs that we have throughout our counties. As Secretary, I serve at the pleasure of Governor Shapiro and all Pennsylvanians, especially those struggling or have a family member or loved one struggling with a substance use or gambling disorder. Throughout the next few hours, I'm confident you will hear about the many accomplishments DDEP has made throughout the last year and learn how we're continuing to work to ensure high quality and equitable prevention, intervention, treatment and recovery support services are available across the Commonwealth. Please keep at the top of your mind that our ultimate goal is to have more Pennsylvanians each and every day living their lives free from the disease of addiction. At DDAP, we believe that all Pennsylvanians living with a substance use disorder deserves access to high-quality treatment no matter where they live, and that treatment and services can be a vital first step on the path to recovery. Governor Shapiro's proposed budget supports that mission. His blueprint for the 25-26 fiscal year recognizes our commitment to providing quality services to those that need it the most, specifically investing $45 million in state funds to be used toward achieving our RISE goals. That's R-I-S-E, which guides my department's work each and every day. Those principles are, R is for reducing stigma, I is for intensifying primary prevention, S is for strengthening the treatment system, and E is for empowering sustained recovery. With that, please know that I invite you all to help us achieve our goals. I look forward to partnering with you in these efforts. Thank you.
Thank you both. We're going to begin with Representative Malagari.
Thank you, Mr. Chairman. And I want to open up by first saying thank you. Thank you to Secretary Bogan and thank you to Secretary Davis-Jones for your work that you do in keeping the Commonwealth safe and keeping it healthy and helping to promote positive health outcomes in our entire population. We know that healthcare and drug and alcohol, substance abuse disorders are not a Republican or Democratic issue. They're not a rural or suburban issue or an urban issue only. They are a Commonwealth of Pennsylvania issue, both. So I want to thank you for the strong work that you're doing and continue doing that good work. I'm going to jump into some questions. My questions are being directed towards Secretary Davis-Jones. So, Secretary Davis-Jones, I want to ask with regard to some equity first. So how does the department plan to collaborate with other agencies and programs, such as the 988 crisis line, to ensure individuals and that are connected to the appropriate substance use disorder services?
Yeah, absolutely. Thank you for asking that question. I'll start off by saying that I am a part of the Health Hub, and so that includes myself, Dr. B, Dr. Bogan, and the Secretary of the Department of Human Services. And so we work diligently to make sure that we're integrating our efforts. And so when it comes to the 988, my bureau director that's here right now, she is a part of a committee that is making sure that our work is intersecting. So for example, while we do have 988, we also have the Pennsylvania Get Help Now hotline. And a part of that effort is to ensure that those that have substance use disorders, that there can be a warm referral to that line, because the services that are offered through the Get Help Now are truly specific to those with substance use disorders. And so we are tracking that data. We are meeting regularly with the 988 folks. And so I'll let Erica talk a little bit more about sort of that transition and what's happening to ensure that substance use is embedded.
Thank you. We work with 988. We establish protocols because we understand 988 receives both mental health and SUD calls. So in order to address that, we have a nice protocol that we establish with 988 that would give a warm handoff over to our 1-800-662-HELP number for any SUD referrals.
Thank you for that. Appreciate that. I have one other question. So this has to do with workforce, and it's an important topic. I'm the proud husband of an LCSW who works for a large healthcare organization in Southeast PA, and understanding that recruitment and retention of drug and alcohol treatment providers is very important. What is the department doing to address the challenges with that, with recruitment and retention? And in addition to that, what's the department doing to elevate this workforce? What's the department's plans to support individual workers who are providing these vital services?
Wow, we have a lot going on within the Department of Drug and Alcohol Programs. I'm really proud of the work that we're doing to support those in the SUD workforce. First and foremost, many of you may be aware that we have a student loan repayment program. And as of right now, we are in the second phase of administering that program, and we're expecting to fund a total of, I think it's 348 individuals with student loan repayment. And we're really excited about that work because what that ensures is that individuals will stay in the SUD field, that they do have a commitment as a result of us paying their student loans. They have to stay within the SUD workforce for a minimum of 2 years. So what I'm excited about is that we're hearing that the program is working. For the phase 1 participants, we recently collected a survey. We got some survey feedback, and I'm going to find that. You have it? Okay. But what we do, our response rate was relatively high. 83% of the round 1 recipients responded to our survey. So out of 200, I think it was 245 individuals, we had 210 individuals respond. And what we do know is that because of the program, they're saying that their work environment feels much better because they have less stress about, focusing on paying student loans. Also, we do know that, if you can, do you have it? Okay, I'm trying to find the actual results, but what we do know is that the participants are definitely engaged. They're still at their treatment facilities, they're working. And in addition to that, we're also about to pilot a recruitment and retention program with 2 universities. One is with Carlow University and the other is Waynesburg. And so it's really about trying to attract individuals to the field. And so we're doing that at the collegiate level as well. And as soon as we find our data pertaining to the workforce survey, I will share that with you.
Yeah, please share that with us. Really do appreciate it. Thank you so much for your testimony. Thank you for your answers. Thank you, Mr. Chairman.
Thank the gentleman. Representative Krupa.
Thank you, Mr. Chair. And thank you to all the testifiers here this morning and coming and sharing your expertise. My first question is for Secretary Bogan. During the governor's budget address on February 4th, he stated that he directed the budget secretary to conduct a comprehensive review of every program we offer in the Commonwealth to identify inefficiencies and costs that can be eliminated. I'm very glad to hear this given all the discussion about identifying and reducing fraud, waste, and abuse. This initiative, known as REMAP, is incorporated in the budget proposal by sunsetting programs that are duplicative and don't work. However, my understanding is that your agency and department was not part of that initial review. Have you had any conversations with the governor and/or the budget secretary regarding your future involvement in that review process?
Thank you. The REMAP program, we were not part of the pilot departments that worked on REMAP. However, we have undertaken a lot of that work already, and we look forward to working with the governor and the budget office on the formal REMAP. But in the Department of Health, we have a small office called the Office of Operational Excellence, and that small office reviews our programs and helps us find ways to improve process and efficiencies in our program. The same office is also helping us with our strategic planning and making sure that our strategic plan, our mission, vision, and our programs all align. That is part of the work of the strategic planning. So we've been doing that throughout my time at the department. We have done a number of things related to efficiencies, looking at our positions and making sure our positions align with our mission and vision, as well as, of course, our funding. And we're also we've done a number of things with our lease agreements. So for instance, we have about 58 state health centers across the Commonwealth. We've, over the last couple of years, co-located 10 of those so far with offices, county assistance offices. We've 8 more planned, and we're continuing to try to, again, consolidate and make sure that we have then access for people, right? So if you come for a health service, you can also go to your county assistant's office. We have also done a lot of alignment around making sure that our programs are not siloed and that they're working together. So, we have the WIC program across many of our counties, all of our counties. We have our state health centers, and again, making sure that all of our services align and are as cost-effective as we can. So we continue to do that work. We're looking forward to actually the REMAP program and working when it comes our turn to work with that office.
Thank you for taking the initiative on the internal reviews, even without that formal requirement. The reviews that have been taken internally, are those publicly available?
No, I mean, they're really the sort of day-to-day working, making sure, again, we're communicating really effectively. If we have information that needs to go out to people. So for instance, there's some programs that are adjacent to WIC but not part of WIC. We make sure we get information across. We make sure that if we have people who are attending meetings on department in one area, make sure that that information is communicated to other areas. So we've really worked a lot on internal communication, reducing redundancy, meeting attendance, things like that, to really try to improve efficiencies.
And thank you for that. As much as I want to do a deep dive in that, for time reasons, I'm going to direct my next question to Secretary Davis-Jones. Madam Secretary, the governor's budget proposal assumes that adult use cannabis or recreational marijuana will be legalized in Pennsylvania in 2025, with sales starting in 2026. As the chief drug and alcohol treatment professional in the Commonwealth, what is your professional opinion about legalizing adult use cannabis and the burden that that will put on your department?
Yeah, well, thank you for asking that question. And I'll just begin by saying, first and foremost, that the Shapiro administration firmly believes that a substance use disorder is not a crime. And when it comes to things like adult use cannabis, I think it's really important that we really focus on what it is.
Excuse me, can you talk into the microphone a little bit?
Oh, sorry.
Thank you.
Sorry. We really focus on what it is that our department is charged to do. And so the legalization of adult use cannabis is definitely outside of the scope of my department, and the authority definitely sits with the General Assembly.
And I appreciate that, but would you agree that particularly with goals, and their admirable goals of ensuring high quality prevention and a life without addiction, that those goals are going to be harder to reach when we are broadly allowing and permitting and promoting by the state adult use marijuana use?
Yeah, I'm just going to state once again that our role is to truly provide prevention, intervention, and treatment services across the Commonwealth. And when we think about things like alcohol, which is legal, when we think about gambling, which is a legal activity, our department is here to support someone should they have a problem with any of those things that are considered legal activities. And if that should happen as a result of adult use cannabis, our department will be here to support those individuals.
Unfortunately, my time's expired. Thank you for your testimony.
Thank you.
Thank the gentlelady. Representative Gallagher.
Thank you, Mr. Chairman. Thank you, Secretary Bowen, and your staff for being here today. With the increase in skills games in Pennsylvania, what are the department's concerns regarding its impact on individuals, particularly in terms of addiction, problem gambling? How do you foresee the departments working alongside other agencies to address any potential challenges?
Thank you for the question. My response is very similar. We currently do provide services for those with gambling use disorder. And so with skills games coming potentially into the process, we firmly believe that we'll continue to be able to support not only through being able to provide treatment services if needed, but we're going to also continue to provide gambling prevention services. And so we are actually building out our current team to be able to address any additional supports that may be needed. But again, if considered a legal activity, we will be available, our department will be available to address any needs.
So that leads to my second question. Are you seeing an uptick in calls in regards to skills games?
Not at this time.
will you guys be tracking that to see if people are gambling on those machines? And in the future, do you think you will be able to support and share data that shows the uptick or how that transpires?
Absolutely. We are currently tracking. We are required to submit an annual report on gambling. Am I saying the right? It's either gaming or gambling, both gaming and gambling. So we actually have some current reports right now on our website. And so it is a charge of ours, and we'll continue to do so.
All right,
we
thank you so
currently-
much. Oh, sorry.
And we currently work very closely with the Pennsylvania Gambling Control Board, so it is very much a collaborative effort between us and them.
All right, thank you so much. Thank you, Chairman.
Thank
you.
you, gentlemen. Representative Barton.
Thank you, Chairman Harris, and thank you all for being here today. I'd like to direct my question to Secretary Bogan, if that's all right. And Secretary, I come from the 124th Legislative District, which serves Berks and Schuylkill County, and very rural communities in that part where I serve anyway. We have 2 St. Luke's hospitals, and we also have 2 Lehigh Valley hospitals, Lehigh Valley Health Network hospitals that I serve as well, that are just outside the district. But there's just many issues that are plaguing hospitals across the Commonwealth. And I know you've heard this before, but workforce shortages, emergency room boarding, difficulties discharging complex cases, regulatory challenges, and it goes on, doesn't it? But these issues can be exasperated in rural communities like mine. And these issues have been discussed in the last 2 budget hearings with your department. However, we're seeing these trends continue. We're seeing just troubling issues going on and on and on. Over the last several years, we've seen full hospital closures under both urban and rural parts of the Commonwealth, not necessarily in my district, but across this Commonwealth, and partial closures of facilities, leaving healthcare gaps in these communities. Most recently, UPMC Cole in Potter County announced they are ending their labor and delivery services. Understanding that you as Department of Health are not a payer, and part of this responsibility lies with the Department of Human Services. Dr. Bogan, what are you doing to help hospitals, particularly rural hospitals and rural health?
Yeah, I appreciate that important issue. You know, the Department of Health's role in hospitals is really a regulatory one. And so we are working really closely across the Shapiro-Davis administration. As DDAP secretary said, the health hub secretaries meet weekly. That includes DHS, DOH, drug and alcohol, aging, and our insurance commissioner. And we talk a lot about rural health. And as a matter of fact, last year the governor did convene many stakeholders, and we continue to meet regularly to discuss it. I've also been out visiting the rural hospitals to really see the impact on communities. So we're doing a number of things. The governor has, you know, the issues affecting rural hospitals include workforce, retention, that's a big one, payment systems, a shrinking population. And again, in order to keep a hospital open, you need to have patients there. So again, how do you attract? And so these cross not just the Department of Health's work, but really broadly. So we are working as a community to try to come together on this. One of the issues we're doing at the Department of Health is really looking at flexibilities, and we have an exception request process that we look at each individual request, and we have received some from rural hospitals that have made a difference. We continue to use that exception request process. We're also currently reviewing our hospital regulations, and hopefully there'll be some changes in that way also. Again, those are directly things that the Department of Health oversees. And the governor has proposed some loan repayment programs, expansion. We currently do loan repayment programs, and we have the J-1 visa program that bring healthcare providers addressing workforce. And frankly, at a number of the hospitals I've been to visit in these rural communities, those longstanding loan repayment programs and the J-1 visa programs have had major impact on keeping people in those communities. They go there for a couple of years and then they stay because they have a wonderful experience. So this is an expansion of a request to expand the loan repayment program, as well as other opportunities to bring the workforce into rural hospitals. So those are some of the things, but again, there are also issues happening in DHS. DDAP is working on some rural health things, as well as DCED and other parts of the administration.
Thank you. And I get we can't control everything, but we can control the conditions that help our hospitals operate, and we're losing right now. We need to reverse these trends, and I appreciate all your help that you can do to continue to make that work.
Well, we're open to ideas and suggestions and happy to keep meeting about this. Again, this is going to take all of us working together. This is not one person's to fix. This is a all of us together opportunity.
Thank you very much,
Thank
Secretary.
you.
Thank the gentleman. Representative Khan.
Thank you, Chairman. Thank you, Dr. Bogan. Thank you, Dr. Davis-Jones. I want to actually kind of piggyback on the last question from the gentleman from Berks and Schuylkill. I remember back in 2019 when Hahnemann closed, and so many, I think there were over 800 union nurses from PASNAP that lost their job. I had patients that I had referred for testing, mammogram, other specialist consults at Hahnemann. I don't know whatever happened to those that were sort of lost in limbo when they shut down. We had a private equity firm buying a public good 171-year-old hospital that had existed for so long, it served so many patients, and within months of them buying it, that place was shut down. We saw something similar when a for-profit organization bought Community Hospital MCP in East Falls, where I represent, and the community again, and this actually happened a few months after, about a month after a nurses' strike. Representative Borowski and myself and other legislators are working on legislation that would actually help to give the Attorney General more power to really guard against some of these bad actors, whether they be private equity, whether they be for-profit, that are looking to either acquire, merge, consolidate, but end up shutting down hospitals, or actually may do a transaction that may not be good for our community. So can you talk a little bit about some of the efforts that you all are doing to sort of guard against this? And a piece of legislation like that might be something that you all could get behind?
Yeah, I appreciate the question. The governor talked a lot about private equity in his budget address. We see it every day in the impact on a number of our hospitals as well as our long-term care facilities, especially those leaseback agreements that really can inflate prices on facilities and contribute to the debt, where you have facilities operating on tight margins already that just pushes it. And these facilities require a lot of maintenance, right? And so there are a lot of costs built into maintaining facilities in a quality situation. So I think it's essential we consider all the tools we potentially have. And scrutinizing the financial status of healthcare facilities during change of ownership, I think, is one real opportunity to make sure that our facilities remain open and healthy and can support the communities in which they're located. So really look forward to having discussions with you about your bills and what we can do as a community to address that. Before I was at the Department of Health, the long-term care facilities regulations were updated, and that includes the ability during change of ownership as well as license renewal to renew the financial statements, audited financial statements of those facilities. And we built a team, thanks to funding from the General Assembly, to be able to use those financial statements to understand the financial status of the institutions. And we did, this past year, deny some change of ownerships because of our ability to do that, because of our concerns about financial status with long-term care facilities. And we would be open to discussions about how does that work, and what have we learned from that work, and how can we use that for hospitals as well.
Thank you. I should have actually preceded my comments with two statements. First of all, thank you for the work that you all do. Also, happy Black History Month. I want to ask Dr. Davis-Jones about peer recovery services. We have one actually in my district, Unity Recovery, and obviously this is an issue that affects not just urban, but also rural. It affects our entire Commonwealth, our issue with substance use and individuals not being able to get access to treatment. This peer recovery support is actually something that I learned about recently, and it makes a lot of sense where you have people who had been previously going through substance use that have recovered and now have been trained to help others that are going through it. Can you talk a little bit about what supports currently exist for peer recovery support, and also would you be supportive of an initiative? It's actually a bipartisan bill that I have, Representative Flick, that would actually allow the state to use Medicaid dollars to reimburse this care, peer support recovery.
Yes, thank you for the question. Right now, through our department, we have a focus on empowering sustained recovery, and a part of that work is to ensure that peer support services are available across the Commonwealth. Therefore, we do have non-regional recovery hubs across the Commonwealth. Unity Recovery, in fact, is one of our hubs. When you think about all of the services that are available, I just want to spend a little bit of time. We are currently allocating just roughly around $24 million for recovery support services, which also includes recovery housing in the tune of around $14 million. And so when you think about what's available under the recovery support umbrella, we're talking about, again, everything from recovery housing, peer support. We have recovery, health and wellness, educational events, in addition to transportation supports, peer-led recovery workshops, and other housing-related supports. And so right now, those things are currently being funded through the Department of Drug and Alcohol Programs.
Thank you. Thank you, Chairman.
Thank the gentleman. Representative Alsumer.
Thank you, Mr. Chairman. And thank you all for your testimony today. I really appreciate and look forward to hearing what you have to say. Secretary Bowman, this is for, my question is for you. So I come from the 139th District, which is Southern Wayne and Pike County. And unlike a lot of other districts throughout the state of Pennsylvania, this is a rural district. It is a growth area. And there are no hospitals in my district. It's a strange environment where if you go down, you're in an ambulance, you have to go to New York, you have to go to take a 45-minute ride or an hour ride to another hospital. So the idea came about to build a micro hospital in our district. Our local Pike County commissioners have been spearheading that issue. And they've run into significant obstacles along the way. And honestly, this highlights a real concern and safety concern that probably a lot of our colleagues could experience throughout the state of Pennsylvania. You know, these critical obstacles that they're facing are things like 35-mile radius. Some of these are federal and state. Building in an existing facility. So obviously in our district, there is no existing facility. Census requirements, funding is a huge issue. And if they are to partner with an existing facility or an existing license holder, they have to do that within 30 miles of the existing license holder. In our districts, it could be 70, 80, 100 miles or more across these districts. So these are significant issues. Madam Secretary, what exceptions can be made for rural micro hospitals hamstrung by federal and state regulations? trying to build a new facility. And can you specifically name some examples of what you have done?
Thank you. That is a question I think I need a little bit more time to think about, because there are, as you mentioned, quite a few federal regulations that we can't address directly. But I think having discussions about where our exceptions of ability and which are federal, which are state, I think is an important starting point. And I don't want to speak without reviewing the regulations, because there are, for rural emergency hospitals, there's some criteria. For critical access hospitals, there's others. For micro hospitals, there's another one. And so without being prepared to respond, I would rather wait. And if I can get back to you on that, I'm also happy to set up a meeting and talk about that. I think it's incumbent upon us to try to come up with creative solutions.
Yes.
And trying to overcome barriers that are there with good intentions, but may not be practical. So I wish I could answer that right now, but I would feel better if I could meet with my regulatory team and make sure I'm as well informed as I could be at the time to discuss the details, because I think the question you're asking is important, but I just would not be able to address those specific questions at this moment.
Understood, and I would greatly appreciate the opportunity to meet with you, maybe with the commissioners that I mentioned before, to review those issues.
Yeah, can I just comment, we are working, I think it is an opportunity to think about regional healthcare, and how do you consider regional alliances to make sure that there is access to care for people. And I know that the Department of Human Services and we've had multiple discussions about how do we do that. So I look forward to the discussion.
Thank you, thank you. So sticking with rural Pennsylvania, the Pennsylvania Rural Health Model with the Centers for Medicare and Medicaid performance period ended December 31st, 2024. And it's my understanding there is a 2-year wind down period for Medicare. Can you please share what is being done to assist these rural hospitals, and what efforts are underway to ensure the viability of these hospitals if the demonstration is not continued?
Yeah, I'll try to keep my comments brief if that's okay. So the Pennsylvania Rural Health Model was a model that was developed, about 6 or 7 years ago. And it was with the Centers for Medicaid and Medicare Innovations, CMMI. They did notify us that they were going to not be continuing it, that there was going to be a 2-year wind down. 16 of the 18 participating hospitals in the PARM model have continued participation in the Medicare only. I think it's really important, we have over 60 rural hospitals in the state, and only 18 participated. So we really want to think about what are the opportunities across all of those hospitals going forward, and what have we learned. The great news is that all 18 of those rural hospitals are still opening and providing services in their community. And we're working with the governor's office, with the rural health, the RHRCA, and Janice Walters and her team to come up with solutions that will affect not just those 18, but many. One of the lessons we learned from the PARM model is that it's a little bit complicated, and making it simpler will help, I think, engage more hospitals into programming. So we have to think really broadly, not just the global payment system.
Thank you, Madam Secretary.
Thank the gentleman. Representative Waxman.
Thank you so much, Chairman. First, let me just echo my colleagues, just how grateful we are to all of you, to your department, for the work that you do here in the Commonwealth every day. It's vital, and we just thank you so much for your service. 80% of DDAP funding is federal pass-through. Is that correct? Yeah. And what would be the likely ramifications?
About 75%.
75%.
75.
Pause.
And that's a variety, it comes in a variety of ways.
1 second, Representative. Can you, we can't hear you.
Oh, sorry. That it's around 75%.
Thank you.
It's around 75%, and that's a combination of grants, and how does the funding flow from the federal government?
Yeah, we get a variety of grants from the federal government. We get the state opioid response funds. We get the substance use block grant funding as well. We've had some COVID funding that is definitely winding down. So we have about, I think there's 4 different federal funding streams that we currently receive. And most of that funding actually goes to either grantees or directly to our single county authorities.
And in recent weeks, since the new administration took over, we have seen aggressive moves to reduce the funding available for these types of programs. Is that correct?
We haven't heard much specifically on whether or not we will be receiving any cuts from the Substance Abuse Mental Health Services Administration at this point in time. We recently had a meeting with them, and so what we do know is that their department is currently under review, but beyond that, we haven't heard any specific potential, any information about potential cuts at this point in time.
There is no specifics yet, and quite frankly, the entire operation seems fairly disorganized at the federal level. It just, but what is it that could happen? Just some examples of programs, of impact, of services, given just the large reliance on the federal funding for the programs.
If you look at our current budget right now, and just even with our staff complement, 76 of our 122 positions that are authorized are funded through federal dollars. So that would be, a significant cut if they should remove those funds for some reason. Additionally, we fund lots of services, everything from prevention, intervention, treatment, and recovery supports, along with harm reduction with those federal funds. One of our programs that we know is currently working to reduce overdose deaths is our overdose prevention program. And should we receive substantial cuts from the federal government, we would have to revisit and reimagine that life-saving program. So my hope is that we will not receive any cuts and that the Trump administration will consider the livelihoods of those that need services the most.
And just so that we are clear, the services that we're talking about are services that are available in every part of the Commonwealth and are services that are available to almost the broadest scope of the population of this Commonwealth and will impact everyone.
Absolutely.
So, okay. Well, thank you so much for being here again. I appreciate the time, and I appreciate the answers to try to illuminate what the real impact may be of some of the rhetoric and, quite frankly, disturbing actions out of Washington, D.C. Thank you.
Thank you.
Thank the gentleman. Representative Mustello.
Here. Oh, thank you, Chairman Harris. Thank you all for coming this morning. And Secretary Bogan, I have a couple of questions for you, if you don't mind. I've been hearing a lot from nursing homes regarding the staffing ratios and how the department has instituted these compliance surveys that, as I'm to understand it, they started back in 2023. And the surveyors are applying these staffing ratios in very, very strict manners and without really considering the good faith efforts made by these facilities and the nursing homes, and to meet the staffing requirements that are required by your department. Life's going to happen. I mean, you're going to have call-offs, you're going to have weather-related issues, especially what we're having out west right now. And, I understand that well-intentioned, sometimes burdensome, sometimes costly, and these facilities, as I'm hearing from them, once a week, that they're relying a lot on outsourcing of contracts of nurses to come in. So my question is, what really started this? Why did the department impose this back in 2023? Why was this instituted by your department?
Thank you so much. The long-term care regulations were updated in 2022 and have as part of that discussion, again, preceding my time at the department, those long-term care regulations were really a balancing between, patient safety and making sure that patients have access to quality care, staff burnout, and other things. So those are the regulations that were approved. They went through the entire regulatory process.
Of the state or of the feds?
The state.
The state did those.
These were
okay.
state regulations that were passed in 2022. The staffing ratios were part of that. It was a two-phased scale-up of requirements, and it requires staffing time. It also requires a number of hours that people receive direct patient care in those facilities. And again, it's really important to understand that the purpose of those is to ensure that people get the care they need in those facilities, as well as protecting the staff. So I will say, so those are in effect. We have been monitoring closely when we go and do our surveys of the long-term care facilities, and about 80% are currently meeting the staffing guidance. We have been citing people, but not giving particular, what's the word, I'm forgetting, fines?
Yeah, there's not enforcement associated with it directly.
And when we
But
look at
there
the
is a
facilities,
burden sometimes on the facilities,
well, the
right?
facilities are, when we look at the facilities that are not meeting the staffing ratios, they're also, most of those are also not meeting other issues that our regulations require as well. So, but we work very closely. So I really want to tell you what is most important is that we recognize that this is really hard. And this is not easy for people, but we have our long-term care transformation office. And that office was formed coming out of COVID. We realized that these nursing facilities need support. They need support on staffing. So we conducted quality investment pilot work, and I'm really happy to report the results of that. So last year, when I was here, I told you that we gave funding to about 100 long-term care facilities across the Commonwealth. And those were really picked based on a number of factors, including the proportion of their patients that were Medicaid insured. And we did a return on investment in those small pilot projects that were anywhere from $20,000 to $100,000.
Okay.
And we saw that we reduced, in those small investments, working on workforce issues, reduced the need for agency staff, and kept retention. So
Right.
really important work
Good.
that's happening.
And how long then will these continue? Is this going to be an annual survey that you're going to do, that you're going to go into these facilities every year?
So the quality investment pilot projects through the Long-Term Care Transformation Office, in the budget, there is a request to continue to be able to do those quality investment pilot projects. It's in the governor's budget proposal. That work has been federally funded up till now, and we're asking, because we can demonstrate the impact of that work, that you continue to support that effort so we can continue the work to provide quality care in long-term care.
So you can provide the data that you have been, have you provided that to us yet?
We just finished our return on investment analysis, and we'd be happy to provide you some of the data in a comment back. We provide a response to questions and be happy to provide the long-term care. I mean, I have the data. I can read it to you if you'd like.
Well,
Kristen.
no, that's fine. I think you can just, I don't think the chairman would appreciate that if we went over with the red dot. But so that is information that you can provide to us.
Absolutely.
But I mean, you have to understand that there just aren't the nurses that they're producing coming out of schools anywhere anymore, whether it's hospitals, long-term care facilities, it's anywhere. So I do hope that's being taken into consideration when these surveys are being done.
Yes, and again, I think in the governor's budget are a number of workforce initiatives that are aimed to address the shortages we have across the workforce in healthcare.
Right.
So look forward to working with you all on those initiatives because they really are important.
And I'm looking forward to that data. Thank you. Thanks, Mr. Chairman.
Madam Secretary, if you could provide that data to both myself and Chairman Struzzi. So
We would be thrilled to provide that data to you.
and we'll share it with the membership. Thank you. Representative Mays.
Good morning, and thank you, Chair. Thank you, Secretaries, for being here this morning. Happy Black History Month. I want to thank you for the work that you do to keep all Pennsylvanians safe, but especially our moms. Also, as co-chair of the Pennsylvania Black Maternal Health Caucus, I want to thank you for your leadership and thank you for your partnership and dedication to reverse the disturbing trends of Black maternal mortality and morbidity. I also want to invite you both to our statewide Black Maternal Health Week festivities in the city of Pittsburgh, April 14th through the 16th. I have quite a few questions, so I want to try to get them in as quickly as possible. The first is to Secretary Bogan. Quite a bit of your budget, as my colleague from Philadelphia mentioned, does come from the federal government. And so we have such uncertainty about if those dollars will remain in play for our Commonwealth. And I particularly wanted to ask you about programs like WIC, the Supplemental Nutrition Program for women, infants, and children. How could losing dollars at the federal level for programs like that impact moms and families across the Commonwealth?
So lovely to see you. Our budget is about 60% federal dollars to the Department of Health, and that we have quite a few programs that are fully federally funded, including the important WIC program. WIC has been demonstrated over decades to have impact on the health of its participants. People who participate in the WIC program have better birth outcomes, and their children have better outcomes. So we would really be sad if that program were not continuing to be federally funded because of the impact it has on so many. I mean, 50% of babies born in Pennsylvania are WIC eligible.
Oh, wow.
And we have worked really hard across the state to increase our WIC participation over the last couple of years, really seen increase. We're about 200,000 participants at this point, and that was one program. We also have a number of other. Our immunization program is fully federally funded, except for one position. Our emergency preparedness is 100% federally funded. So again, we are watching the situation closely and trying to follow what's happening to make sure that we can provide continual, important public health services across the Commonwealth.
Thank you so much, Secretary. I may have to come back up for a second round of questions. I'm going to actually turn to Secretary Davis-Jones. Substance abuse disorders and pregnancy criminalization is going to be an important theme this term for the Pennsylvania Black Maternal Health Caucus. In the Pennsylvania Maternal Mortality Review Committee report, I saw that about 40% of the maternal deaths, a substance abuse disorder contributed to that maternal death. So what is the impact of substance abuse disorder on pregnant women and moms who may especially be postpartum? What are their unique needs, and what are some of the strategies that you are seeing that work within your department?
Yeah, absolutely. So when you think about, the impact of substance use on moms and babies, the impact is truly significant. So we're talking about everything from preterm labor, placenta abruptions, eclampsia, miscarriages, stillborns, low birth weight babies. When you think about, if a mom is drinking alcohol, there's a chance of fetal alcohol syndrome, neonatal abstinence syndrome for moms with opioid use disorder. And we're also talking about, moms who use drugs, pregnant women who use drugs also have co-occurring disorders often. And so we're talking about the mental health implications tied to that, everything from depression, anxiety, and trauma-related disorders. And there's also, of course, an increased risk of overdose. And so when you think about some of the work that our department is charged to do, it's really about whole person care, right? Making sure that moms have access to the services that they need. And so we're talking about everything from case management, transportation support, making sure that they're being screened for mental health conditions, and if needed, that they're referred to those services, and also ensuring that they have access to high-quality treatment programs. And some of the things that we funded, one of the programs are right here in Dauphin County. We have a program that we fund, it's called Baby Love. It's at the Hamilton Health Center, and it is showing to have phenomenal outcomes. I do have some of that information with me. What we do know for 2023, 2024, for example, 84% of the mothers remained engaged in treatment, which was really important. 96% of the mothers that were enrolled in treatment did not need a higher level of treatment after being discharged, and that was at the 90-day mark. We also know that 98% of their babies did not require extended hospital stays as a result of NAS. And last but not least, 89% of the moms that were engaged in the program, they actually received prenatal care during their first trimester, which is so important.
Thank you. So those sound like, that sounds like the kinds of strategies we need to be investing in as a Commonwealth and look at the co-occurring issues that come with being pregnant and, experiencing substance abuse disorder. Absolutely. Thank you both. Hopefully I'll be back for some more questions. Thank you, Chair.
Thank you.
Thank the gentlelady. Let's please remember, when the yellow light is on, that means 30 seconds. We should probably not ask another question at the yellow light. Thank you, Representative Marcel.
Thank you, Mr. Chairman, and thank you to all of you for joining us this morning. I wanted to, hopefully I have enough time to ask all my questions, but the first one I wanted to focus on is, so Act 43 of 2023 had to do with a number of areas relating to xylazine. I had a bill that ended up becoming part of Act 43. My legislation required DDAP to engage in a public awareness campaign to educate the public about the dangers of xylazine. I'm very happy that that ended up making it into law. I wanted to see if you could provide me an update on, how that is going in terms of entering into partnerships, creating educational materials for the public.
Yes, I'm going to actually turn it over to my colleague to talk a little bit about that work that we're doing, but we're doing that in collaboration with the Department of Health. We have definitely already began to create some educational materials, but to sort of add a little bit extra context and color, I'm going to turn it over to Erica.
Sure. Thank you for the question. So we really are taking a very harm reduction approach when it comes to xylazine and wound care. We have currently expanded those services to our local drug and alcohol agencies so the information can get disseminated statewide. We worked very close in collaboration with our partners at the Department of Health. They're at the forefront of gathering solid information about how to be able to address those medical concerns that are that could result as a result of xylazine.
And I appreciate the update. I guess my concern is that when I go on your website, it's very hard to find anything. If there are materials, I'd love to see them. I'd love an update of some sort, because when I look at data, and actually this was from a May 2024 release from Governor Shapiro's office, the press release talked about that in 2023, xylazine overdose deaths were about 1,135, which was a 22% increase in 5 years. So in 2018, we're only looking at 51. So we have a problem, and it's hard to find anything on your website. And I get it's only been a year, so I want to give you time to do this appropriately to help people. But if xylazine is present in over 90% of drugs in Philadelphia, I feel like, time is of the essence, and I'd love to be able to see what you're doing. If you can share updates about materials, what are the partnerships that you're entering into? I saw something that there's a training next week that is with the Savage Sisters Recovery. It's a trainer, but it's $20 to participate. Why are we charging people to attend this? So I guess I would love to get a better sense of how are you implementing this, because I was hopeful that this would be helpful with the people of our Commonwealth. And I just want to make sure that you have what you need, that we're moving forward, and that I can see that you've demonstrated that you're actually fulfilling Act 43, because I'm very concerned about that. And I don't believe that we should be charging people to attend trainings when we've asked in that law for you to do these partnerships. I don't think charging $20 to attend a webinar is fulfilling Act 43. So I just wanted to just mention that, and I hope that you'll provide more updates to us in the future.
Yes, and absolutely. And I should say that, again, We are providing training. We are issuing several grants. During this past fiscal year, that definitely has the ability to address all things related to xylazine, wound care, harm reduction.
I'd love a full report whenever you have
Yep,
time. I know that I'm
absolutely.
very limited in what I can ask about in my time, and I don't want to go over so I can be respectful of the chairman. I was actually going to move on to Narcan funding. In your testimony, you highlighted that in 2024, DDAP became the sole administrator for the overdose prevention program. In 2024, your department distributed over 822,000 doses for Narcan. How does your department determine where those are distributed? And are you looking at trends throughout the state in order to, help you to figure that out?
Yes, absolutely we are. We are looking at the data that we receive. I actually have one full FTE that dedicates her entire time to this project. And so what we do have is what's called regional entities across the Commonwealth. And so we are assessing to ensure that we have coverage throughout the Commonwealth, and we're also working with community-based organizations, hospitals, universities, colleges, schools to ensure that access to life-saving products such as naloxone and test strips are being made available. And we are tracking the results of what's happening, where it's going. If we feel that there are gaps in certain parts of the Commonwealth, we are reaching out and making connections so that we can ensure that either the existing regional entities, that they can take on other counties or communities, and if not, reaching out to other partners so that they can be a part of our overdose prevention program. But I'd be more than happy to share additional information if needed.
Thank you, and I am out of time, so I will follow up to ask the rest of my questions. Thank you, Mr. Chairman.
Thank the gentlelady. Representative Fleming.
Thank you, Mr. Chairman. Good morning. Welcome, everybody. So I wanted to start with Dr. Bogan and mention that the state has a health implementation plan called the SHIP. Could you detail some of the elements of this plan and let us know where we are currently in terms of implementation?
Lovely to see you. Thank you. Yeah, the State Health Improvement Plan is our plan to try to really address big public health issues. And the way that we call it the SHIP, and we have a motto at the Department of Health, we say we're getting SHIP done. Sorry, I couldn't resist.
That was pretty good. Yeah. You get like a 7 for that one. That was pretty funny.
I need at least 1 per hearing. So the SHIP is really important because it is really meant not just for the Department of Health, but for the state to look at the most important things. So the way the SHIP is designed is it's community engaged, right? We ask thousands of people across the state about what do they think is most important. We share data with them and say, what are your values and how do you think? So we have 3 sort of underlying goals of that. One is whole person care, addressing chronic disease, and the third is equity and health equity specifically. And health equity, we use our data across the state to say, where are we seeing high rates of cancer? Among which populations are we seeing them? Where do we see higher rates of infant mortality, maternal mortality? And then we use all that data to inform the State Health Improvement Plan. We have now put up on our dashboard what we call the State Health Assessment Dashboard, so you can look at all the metrics we have broken down by various things, rural, urban, county, race, ethnicity, if we have it, gender, sex, all available for people to see. And then we're also working on a State Health Improvement Plan, or our SHIP dashboard, which will be up soon. And then people can see the tracking that we're doing. So under each goal, we have 8 sections. There are specific metrics that we measure, and we want the public to follow along. And what we've been doing is really engaging with community-based organizations and healthcare organizations across the state to understand the work they're doing. How do we make people work better together and reduce redundancies but improve impact? And so that's the general gist of the SHIP and our Getting the SHIP Done initiative. and I'm happy to share more. And we'll send a notice out in our Health Matters when our SHIP dashboard goes live.
Excellent. Yeah, and I really look forward to seeing those outcomes. I mean, I think when we talk about healthcare policy, the more we work in collaboration and with our community partners, the better. And on that note, so I'm going to switch to Dr. Davis-Jones. Dauphin County is very fortunate to have a Department of Drug and Alcohol Services. I'm just curious, how does DDAP interact with each county drug and alcohol agency? Do you provide funding, training, et cetera? How does that interplay work?
Yes, absolutely. Right now in the Commonwealth of Pennsylvania, we have 47 single county authorities covering the 67 counties. And so much of our work, we really consider those single county authorities, also known as SCAs or local drug and alcohol offices, as the true boots on the ground, right? It's because of them that the services that are being provided across each county is happening. We fund them. We also provide training for single county authorities along with the substance use disorder workforce. So it is a true collaboration. The work cannot be done without the single county authorities.
Yeah.
When you think about what needs to happen, and if someone is looking for treatment, they should be connecting with the single county authorities or calling our Get Help Now hotline. Yeah.
Well, thank you so much. I know I just want to shout them out because I know they are very active in our communities, different community events and things like that. You know, when I schedule things in my district, my office, they are very responsive to us. So I want to laud our commissioners and our county drug and alcohol services agency. Finally, the last thing I want to touch on, I have a constituent who's extremely passionate about this work, and she spoke to me about, and we may run out of time, so I'd like a further update on you know, our residential addiction treatment programs for pregnant and parenting women. You know, I'd like an update on that and to talk about, you know, how DDAP is complying with the law there, and if you can just provide something briefly.
Yeah, we definitely have residential treatment programs for moms. We recently did a listening session in Chester, Pennsylvania at the end of January, where we met with moms from Kindred House along with Samira House. And so while we don't have, I would say, an extreme large number of, you know, residential programs solely focused on pregnant women, but we do have them available through the Commonwealth. And during that, if I could just highlight, the women there were amazing. They really were able to help tell us what's working and what's not working, and I firmly believe it's going to help when we develop our maternal health strategic plan.
Excellent. Yeah, I'd be willing to help expand that in any way we can. So thank you so much, Secretaries. Thank you, Mr. Chairman.
Thank the gentleman. Representative Brown?
Thank you, Chairman Harris, and thank you all for being here today. My question is going to be directed to Madam Secretary Bogan. So specifically related to the health promotion and disease prevention line item that is supposed to address maternal mortality and morbidity. My specific question relates to maternity care deserts. Last year, in February of 2024, there was an article by the Post-Gazette that said, quote, Northern PA will soon have no maternity care. And then most recently, on February 5th of 2025, UPMC put out an article that headlined the importance of addressing maternity care deserts. So we started with 5, and as I understand it, we're now up to 9. In my own area, which is Lawrence County, my daughter recently delivered a baby and had to drive to Ohio to deliver the baby. This week, as we talked to the Department of Transportation, we tried to address this same issue, and asked about options for pregnant moms to get to hospitals, because in my area, they would have to drive 45 minutes to deliver a baby. And their answer was that they could use rideshare, which quite honestly was offensive to me, being a mother and a grandmother. So during the questioning of last year's budget hearing, your department stated that this particular funding would be utilized to hire staff and to issue an RFP to implement, quote, boots on the ground. Can you please share how the hiring of this staff has worked towards the goal of the Maternal Mortality Review Committee?
Thank you, Representative Brown. Maternity care deserts are important to all of, really for us all to address. Again, this gets to the rural healthcare issue. Maternity services are essential. I'm a pediatrician. I spent my career spending time in the newborn nursery and taking care of families during this amazing but challenging sometimes time. And traveling is really challenging when you need to deliver your baby. So the Department of Health cannot prevent hospital closures, right? But we can, that's not the role that we play in a regulatory role. I would love to talk to you a little bit about what we've done. So the General Assembly generously gave us $5 million over the last year or two, really start to work on Maternal Mortality Review Committee recommendations. So most of that money, we formed a small core in the Department of Health whose focus is fully on maternal health. We call it our Division of Maternal Health Services. We hired folks, and those folks are really getting out money to the community. So we funded 4 regional healthcare coalitions that are addressing issues of the Maternal Mortality Review Committee. And when we say boots on the ground, work that's done locally in your communities, that know your communities and can address those needs, because what may work in Philadelphia may not work in Lawrence County.
Right.
So that's one thing. And we are currently working on a number of other RFPs to get out with the rest of that money. We have funded doula programs, home visiting programs. We're working on support for the behavioral health line for like the TIPS line we have for Medicaid, where if you're a pediatrician or a family doc and you have a mental health question, you need a mental health expert, a pediatric psychiatrist, you can reach one as a doctor, call, get a consultation, and treat your patient right there. And we're working on the development of that same program, but during pregnancy, because people have a lot of concerns about prescribing during pregnancy. So it would be psychiatric support for professionals. There's a lot more work to do. So we do oversee the EMS program. So one of the other things we're working on is funding to support education, because people are traveling much farther to get babies, and it's going to fall, unfortunately, to our EMS colleagues often to do that transportation right now as we try to fill in the gaps. We want to make sure our EMS staff are as well trained as they can be to respond to obstetric emergencies. That's not a great answer, but
But I do appreciate that.
So those are that's the type of work we're trying to do. But I think, again, to my comment earlier, this is something we all need to work on together. What are the options? A lot of places, even some places, don't have prenatal care in their communities, but we're making sure that you have to have prenatal care, postnatal care, and delivery care, and all of those pieces have to be addressed. And I think there are things you can do. So we have a pilot project going on right now in Clinton County to use our state health center as sort of a fill in the gap for people so they don't have to travel for every prenatal visit. We're working with healthcare organizations to do that. So I think there are innovations we can do, not necessarily to address the actual delivery, but to address access to prenatal and postnatal care. So happy to have a longer conversation about the challenges and the absolute need to address these maternal deserts.
Agreed. Thank you so much.
Thank the gentlelady. Representative Kozarowski.
Good morning, and thank you very much for being with us today. Clearly, our Commonwealth sees no barriers, and whether it needs health care, access to health care, affordable health care, it needs no barriers with substance abuse, treatment, and recovery. So your challenges are great, and I really do appreciate the work you do here for us in the Commonwealth. Dr. Bogan, my question is directed towards you, and Representative Brown just just touched on it. Now, we could talk about a lot of things, and the chairman's going to be very generous with the time, because I'm the nurse, so I get lots of time to talk. We talked about, private equity in our hospitals and what's happening with closures and access to care and deserts. We talked about, the warm handoff program that for substance abuse. So lots of things, lots of topics, and I feel like we need to have more conversations. But Representative Brown just spoke about access, care, even transportation when it comes to, and sometimes that transportation falls on EMS. And I do know the state medical director for EMS is a part-time position. So given the challenges facing such things as, an emergency maternity delivery, and then getting to our hospitals with the shortage, and a lot of our EMS are now caring for these ER patients in the back of their truck outside of the emergency room, waiting and being told, on diversion, which no ER is actually on diversion. They're walking through those doors, they're coming there, you know this. So I'm wondering, is this should be a full-time position for that EMS director, and what can we do? What would the cost or the legislative action needed to do this? And so we can be partners with you, and is this something we can do?
We currently do, as you stated, have a part-time EMS physician, an emergency physician who is our part-time medical director for our Bureau of EMS. He has been incredibly supportive. His role is really important. He works really closely with PESH and the committee to rewrite our protocols and on training and a number of other things. So his role is essential. We have certainly considered whether that should be a full-time position or not. People are kind of surprised when they learn that our Bureau of EMS is only 15 people. It is a small but mighty group that does really important work. So expansion is always in our thoughts. I just approved a financial person for full-time for our EMS Bureau so that we can get our money out to folks more quickly, again, as part of our assessing where we have gaps in services. So that position will be starting soon, we hope. And one of the other positions we've been considering is whether we need a full-time medical director. At this time, those are expensive costs. These are emergency physicians trained, and their salary is higher than generally is covered under government salaries. And so one is a salary issue, and the other is complement. We have been at our complement cap for many of our line items, particularly for our general operating budget cap all year. And so we need both funding and a complement increase. So we certainly, it's part of the discussion and love to consider that as we move forward.
Thank you. The emergency rooms now treat everybody. And that's why I think it's so important that we, as we talked about these closures in these deserts, patients are seeking care that may have been something that was taken care of by their family doc or other specialties, and now they're in our emergency rooms and they're overloaded, and we hear the stories all the time about the wait time, and it's a crisis. So I'm looking forward to being able to work with you.
Yeah. To my right is Kristen Rodak, and she's been heading up a work group along with a number of our other community partners on emergency overcrowding, because this issue has been raised with us multiple times, and I wonder if I can give Kristen an opportunity just to give a quick update on what we're doing with emergency overcrowding issues.
You can talk as long as you want, because we get extra time here.
Yeah, I'll try to be brief, Chairman. As the Secretary mentioned, we have been leading a work group with both HAP and PA Med and the Pennsylvania College of Emergency Physicians to really bring folks together to talk about the issue of emergency department overcrowding. It's a very complex issue with lots of reasons for why people are ending up in the emergency department. And so really we've been meeting since about midsummer last year with work groups focused on kind of various areas, including primary care, insurance coverage, emergency EMS, diversion, those sorts of things. And we're working with those folks to develop some recommendations, both for the General Assembly and the Governor's office, to think through some policy solutions that might ease some of that burden from the emergency department. So we'll be developing a report over, the beginning of this year, and hopefully have that later this year for you all with some recommendations for what we could do to ease some of that burden.
Thank you. I know it's a very complex issue, so I appreciate that. One quick question. The governor has proposed an increase to the primary care practitioner line item. Can you just provide a little bit of the specifics of what these funds will be used for, related to physicians versus non-physicians, and whether it's specific to rural or throughout the whole Commonwealth?
Yeah, in the governor's budget, there are two parts to the 15 million. 10 million really for us to try to think about how we currently use our loan repayment process, but expanding criteria. Right now, those are really specifically to medically underserved communities as defined by the federal government criteria. And so I think expanding what does that workforce look like, particularly the focus of that is behavioral health. But again, I think that's for some discussion, but we'd like to be able to use the infrastructure that we have already. We estimate that we'd be able to support with that $10 million about 175 more people per year. We currently fund about 75 with our loan repayment program, plus we have J-1 visa, some other, but that would really allow us to put a lot more folks out into behavioral health and into the communities. And then the $5 million is really geared specifically towards rural health. And I think there's lots of opportunities and discussions on how that should be best used, but really workforce into the rural communities.
Okay. Clearly, we need more money and more time. Thank you.
Thank the gentlelady. Representative Nelson.
Thank you, Mr. Chair. Great to see everyone. And really, my questions today are going to follow up on a couple of themes in both departments. So I'll try to be as fast as possible. And I really wanted to kind of pick up where Representative Brown and other representatives from Allegheny County and throughout the state on this issue of maternity deserts. Specifically, you had mentioned that your agency provided funding, because there was $5 million that was applied. Specifically, how much funding went to counties that had maternity deserts? Because Clinton County isn't one of the ones listed unless we have a 10th county now.
I'm sorry, your question is?
How much of that funding specifically went to counties with maternity deserts?
I will have to get back to you specifically on that question, but what we are doing a pilot in Clinton County to try to, because we looked at data on where people are traveling far for getting prenatal care.
So you're doing Clinton because nobody in those other counties can have a baby, so Clinton is and that's
no,
fine.
this is just a single pilot. We will hope to expand it. We started it with one, and we're looking to expand. So that's using our state health center, providing services.
And but of that money, if I'm reading the budget right, in 23-24, 1.9 million has not been spent, and in this current budget year, 2.7 million hasn't been spent. So as we look at priorities, and I agree with your mission. We want quality access to all Pennsylvanians, but it seems like, the department is visiting places, they're meeting with people, there's some funding that is studied, but specifically in maternity health deserts, what priorities, financial commitments does the governor have in this current budget?
So we have another RFP coming out shortly that I can't discuss a lot about because it's going to be put out competitively for the rest of that money for maternal health. And that
and I realize that's, it's his budget, but if we're talking about RFPs of $1 million or working with $5 million, when this budget's spending $3 billion, new money, it's good to know that we're going to get an RFP for a couple of million that may head in that area. And I'm going to move on to my questions because I think there's a lot of work. And the colleague from Allegheny County, she brought up maternal health and recovery, and I'd like to shift to DDEP if I can. Thank you first of all for bringing your entire staff to Westmoreland County last year and meeting with our providers. It is our biggest death area in the county. 118 last year, doubling our suicides. But I had some concerns with recurring or establishing stable funds for RCOs. You know, as I understand it, because our recovery community organizations are being effective and the overdose decreased by about 40 deaths, they didn't qualify for grant funding or weren't able to get grant funding, and it almost seems to be an oppositional situation. Can you touch on, you know, stable recurring funding for RCOs? Because I agree with you, they fall under that recovery support umbrella. And I think, you know, when you mentioned RISE, the S and the E, strengthen treatment and empowering sustained recovery, like that's a dovetail fit.
Right. Absolutely. So I will say that I'm not 100% certain what you're referencing when you say that the RCOs, because of, I guess, overdose deaths decreasing, that they could not receive additional funding or stable funding. What I can tell you is that through the single county authorities that are funding RCOs in their geographical locations, they do have the capacity to fund, even so much in the, from the perspective that we allow single county authorities to come back to us a couple times per year to ask for additional funds should they need them. So I'm kind of not sort of certain about
That's great.
why that would be the case.
Follow up with your office maybe on the details, because when we talk about moms and new moms, you know, I was texting with one of our RCOs, and they have moms that are in that program. I mean, it's not just about those moms, it's about everybody, you know, the drugs, the alcohol, and the gambling, and maybe we can work.
And absolutely, and right now, you know, we are required, we have a federal mandate to support pregnant women, women with dependent children, and we are actually exceeding the federal minimum mandate, and we have earmarked at minimum $10 million to serve the particular population. So please feel free to reach out to us. We'd be more than happy to work with you to understand exactly what's happening.
Thank you. And thank you again for coming to Westmoreland County. It was an appreciated investment.
I would like to just add, so the $2.3 million RFP that we're putting out specifically is, one of the criteria is around maternity deserts.
Thank you, Madam Secretary.
Thank the gentleman. Representative Salisbury.
Thank you, Chair. Good morning. I'd like to circle back to a question that was asked earlier about Act 43 of 2023. And that act required that testing be done for both fentanyl and xylazine in emergency departments for acute care treatment. And I know from my own office's experience with the great amount of interest that we've had from our providing xylazine and fentanyl test strips, just how prevalent the use of these substances has become. I wonder if you can talk a little bit more about how that testing in the hospital environment has perhaps been effective in hopefully deterring use or reporting back information about how much use is going on. I'd just like to learn a little bit more since we moved that through the legislature a couple of years ago as feedback on how that's gone.
I do not have access to the data. That would be something that falls under the Department of Health. And so can you speak to that, Dr. Bogan?
Specifically around the testing in emergency departments?
Yes.
I don't have that data with me today. I'm happy to get back to you. I will say that the department has done a number of things related to xylazine this past year. One was we distributed 50,000 wound kits, and with that, specifically wound kits to organizations around the state to distribute around wound care. And as part of that, we did a significant amount of training. So we trained over 500 healthcare providers to recognize xylazine wounds and how to treat them. And we did that. There were two-hour trainings, plus it's available online now through our trained PA system, and I've had a lot of interest and participation in that training. I actually did the training. It was excellent. So we are continuing our work, again, work with DDAP on these programs, but I'll have to get back to you on the actual, I know it's been fully implemented, but what I don't know are the numbers that we've gotten back yet.
Yeah, I would really appreciate getting some additional follow-up information on that, just because it's always important, I think, to track the effectiveness once we move something through.
Absolutely.
So to pivot to an entirely different subject, we have been, I know, in a number of meetings about Gaucher disease over the past, I think, year and a half or so. And I just wanted to follow up and see where we are in terms of ideally getting that genetic disease tested for at birth for infants in Pennsylvania.
Thank you so much. We do run the Pennsylvania Newborn Screening Program, and as part of that, we do a genetic testing from blood spots, dried blood spots, and we also do hearing and critical heart, congenital heart disease monitoring as part of the newborn screening process. We currently screen for all of the RUSP conditions, as you know, the Recommended Uniform Screening Panel that it comes out of the federal recommendations. Gaucher's is currently not on that list. We did receive an application. It was reviewed extensively by a committee of experts convened from both Pennsylvania, and we brought in some external experts. At the time it was originally, the material we provided, it was recommended not to add Gaucher's at this time. However, we have received additional material from the Gaucher's group, and there's a meeting scheduled in the next couple of months to review the newer data. I do want to add that every time we add a new test, again, we have a process for reviewing. We've had a number of applications around other conditions as well. And so we review each one individually with an expert. If we don't have an expert in Pennsylvania, we bring experts from outside. So it's a very thoughtful process. We've posted our criteria and how we do our process online. It's available. And again, a meeting is scheduled to review the new data with the expert committee coming up.
I know when we had a rally in the Rotunda last year about this issue, one of the things that really struck me was that if you have a child born in New Jersey and that child is tested at birth, as they habitually do in New Jersey for Gaucher's, and they're found to have it, your child will be sent to Philadelphia in Pennsylvania to get treatment for that particular condition. But if your child were born in Pennsylvania, in Philadelphia, they would not be tested at birth for that condition. So you would not necessarily know that your child had that in the same way that a child born in New Jersey would have that advantage.
Yeah. When you line up what New Jersey does, we test for a number of things that New Jersey does not, and they don't, so they don't follow the entire RUSP. So we follow the RUSP plus some other conditions. So we screen for some things that they don't, and that's true across all of the states. You know, one of the challenges with newborn screening is how it's funded. And we get a lot of the funds, every time you add a new test, it adds close to $1 million a year for that test in our system, and funding is finite, unfortunately. And every time we add new tests, it increases the cost to the hospitals and to, you know, we have a lot of people in our Plain community who don't have insurance, who pay for their deliveries out of pocket, and they get that charge added. So every test we add adds cost, and what we don't want to do is price people out and then decline the newborn screen, because the newborn screen is one of our most equitable programs in the state. Nearly every baby in the state is screened through the very effective newborn screen. And we identify children with conditions that are treatable and will change the outcome. So I'm a huge fan of the newborn screening program, but funding is limited. And so we'll have to talk about how do you fund as we add more and more diseases to our newborn screening program.
Thank you. I see my time has elapsed, so I appreciate your feedback. Thank you.
Thank the gentlelady. Representative Mako.
Thank you, Mr. Chairman and Madam Secretary, for being here. I got a couple quick questions about a fund transfer, looking at the governor's executive budget, and I was just hoping you can give me a little bit of background on what the idea and thought process was behind it. It has to do with the medical marijuana program fund and shifting those funds to tourism promotion fund. Can you explain why you're trying to do those transfers and you know, what the thought process is behind that? And is there any intended use for relevancy to those programs?
The current medical marijuana program through the Act outlines how the funds are to be used. Some of it is set aside for research funds. And we are not able to currently use those funds in that manner because of the limitations that marijuana remains a Schedule I drug.
On the federal level.
And so we have accumulated funds in that budget item, and we have used those both to make changes to the program and to, but the governor is transferring some of the money out of that fund this year to use for tourism. And that still leaves us quite a lot of money. We currently have out an active RFP for our seed to sales system and other systems that will cost additional funding. So we, again, if we're waiting to hear what happens at the federal government related to cannabis and scheduling, but right now that fund accumulates and is available to use for other purposes. And it's primarily used to support the program, but in this year we are transferring some of the money out of that fund.
Yeah, and it was brought to my attention, if you guys do transfer that fund, you will have like an ending balance of 164,000. Is that about right? That's not a gotcha question, just something along those lines or whatever.
I think that seems high. I don't have, Kristen, look, that seems high to my recollection, but.
And so I guess my follow-on question is, you're taking money out of this fund and going to the tourism fund. Is there an assumption that that'll be backfilled should we pass recreational marijuana? And is that the same fund that would be the funds funneled into that?
Yeah, your amount was correct that you had said. And part of the balance for that, again, as the Secretary mentioned, we do have enough to support the operations of the program with what would be left in that fund.
Okay.
And part of that is we added 17 additional positions in the last budget, so we're working on posting those and we'll be filling those shortly. We also have some additional IT costs associated with the system, both for the seed to sale system and the patient registry that are both critical to operating the program. So we do have some increasing costs that we plan to spend down that fund.
I guess the one trick question then is, what if we don't pass recreational marijuana? What happens to that fund then? And I mean, if I didn't know you guys were going to add positions, but then how do you supplement the funds then if we don't pass recreational marijuana then for that? Is this a one-time deal?
So we're adding positions because of Act 63.
Yeah, the positions support the medical program.
Right.
So those 17 positions were needed in our facility compliance division to support the provisions of Act 63 with the additional permits that came online.
And they will have corresponding funding in perpetuity.
Yeah, we would have enough funding even if adult use does not pass. We have enough funding within the medical revenue to support the program.
Cool. Second question I have real quick. Piggyback on the previous speaker too about the disease state line items. There seems to be significant balances in them. Are you guys able to get the funds out to whoever needs them? And if not, why is that? And is there any way we can help as a legislature to get these funds from the disease state line items?
The special.
Yeah.
Oh, those, yeah, okay. You're using different terminology than these two.
Sorry,
Yes,
yeah.
yes, thank you. So yes, we have been working really hard to get those funds out the door. We've made a number of sort of process improvements at the Department of Health to move things more quickly, consolidating the number of people who actually have to touch the grant process, but it still goes through, the entire process at the state level. So we have been getting. Are there specific ones I can tell you about? Which ones are you particularly focused on? We have a list of all of the grants.
And is there anything we can do to help streamline that process to get these funds out?
Thanks for asking. I'll have to ask my team if they have any specific things. No, I think at this point we have made a lot of process improvements and working on efficiencies in the process.
Perfect. All right. Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank the gentleman, Representative Curry.
Thank you, Chairman. And hello to the Secretary of Health and the Secretary of Drug and Alcohol. It's good to have you all in the House today. My first question is like everyone else's, maternity care deserts. But what I would like to ask you, Dr. Bogan, is what's the real definition of maternity care deserts? Because at this moment, I feel like some of us are wondering why so much is happening around the level of access of care when it comes to maternity care. But do we actually have a definition here in the state of Pennsylvania around maternity care deserts?
There are some federal definitions around deserts, and it's around distance to travel to your delivery hospital. And so there are increasing challenges of people traveling for a long distance for their deliveries. But it's not just deliveries. You have to have access is broad, right? It isn't just the distance traveled. Do you have a transportation to get there? Do you have the time off from your job or your other family commitments to get there? Do you have people that you trust and are willing to go to? So it's a complex issue. I think the deserts issue is like, do you have a facility within range of your distance? But it is a complicated issue around access, and access is a broader issue than just travel.
Thank you for that. And with that being said, I really do appreciate the work that you have done and the governor around Crozier Health System, which is in Delaware County, which right now is creating a maternity care desert in its own. But I want to just bring your attention to the fact that there is legislation right now. It's on the Momnibus. If anybody knows, the PA Black Maternal Health Caucus has a Momnibus, and part of that legislation is to fight against maternity care deserts. The feds have developed a designation of maternity care health professional targeted areas known as MCTAs. Pennsylvania currently doesn't have a way of identifying areas that could be at risk for becoming a maternal care desert. This legislation for the designation is clearly critical for the Commonwealth for identifying these maternal care access zones. What's your commitment to this legislation, if it goes through the House and the Senate, to be able to identify these zones and to remind people that they need to get on the Momnibus to get this legislation passed so we can get to the point where we're actually identifying where these maternity care deserts are?
I look forward to reviewing the legislation and seeing how we can help.
That's great. And I appreciate, again, all your work that you're doing. And one last question for the Secretary of Drug and Alcohol. Going back to SUD treatment for pregnant women in prison, what can we do as legislators to expand the services these women can receive while in prison? What are your thoughts on how we can look to other programs in the Commonwealth, like medical assistance, to collaborate on addressing the needs of these women, especially upon the release when they are transitioning back to the communities? And with that, we know that there's many mothers, pregnant mothers, mothers who are trying to get into treatment, but have a fear of being criminalized in the process. Can you help us with that, Secretary?
Absolutely. First and foremost, I will say that currently here in the Commonwealth, that pregnant women that are incarcerated do have access to care. Many of our correctional facilities offer substance use disorder treatment services. In addition, our department is funding millions and millions of dollars to ensure that individuals get access to medications for opioid use disorder specifically. But you're spot on when you say, moms are being criminalized and that they are concerned. There's lots of stigma. And so I think one of the things that needs to happen is that we need to continue to educate the SUD workforce, whether it is those that work within correctional facilities, we're talking about physicians, and we're even talking about the individuals that are also working in behavioral health organizations. And so it's something that we know that we need to continue to evaluate and monitor, and we need to ensure that we have access to services not only for women that are incarcerated, but also women that are in the community and needing specialized services for themselves along with their children.
Thank you to both secretaries. And as we continue to work on this process, I would encourage us to consider mobile health care, birthing centers, and all of those things that really are good, solid solutions to these problems.
And I probably should just highlight that really quick. We do have several licensed mobile treatment facilities that are happening right now here in the Commonwealth. So Dendenzia is one, Miraki is another. Tedesco Incorporated is about to also have theirs licensed. And so we're expanding mobile treatment services across the Commonwealth and specifically addressing the needs for rural communities that do not have the same access that other communities have. So it's something that we know is definitely needed, and we'll continue to expand access. So thank you.
Thank you for your work.
Representative DeVanzo.
Thank you, Chairman Harrison, and thank you, Madam Secretary, for being here today with your staff. Your office is responsible for allocating a large amount of grant funding. How do you determine your priorities in terms of grant funding? Anybody, Madam Secretary or Secretary Bowden, or whoever wants to take it.
Sure. We at the Department of Health have a number of grants. Most of our grants are very specific and identify the work that has to be done. So we follow the guidance from that. In terms of distribution, we use our data to identify areas of need. And so if you have a specific grant, I'd be happy to address that. But again, for instance, we have an emergency preparedness grant across the state. We work with, as part of that grant, our healthcare coalitions that are across the state that help us in emergency preparedness. So funding with them is across the state. The WIC grant, again, goes across all of the counties across the Commonwealth. So it depends on the specific grant that you're referring to.
And I'll add to the conversation, one of the ways that we issue funding opportunities is through, as Dr. Bogan just mentioned, looking at the data. What does the data suggest? And we build programming around that. In addition to that, we also are engaging stakeholders across the Commonwealth. We've been on a stakeholder engagement tour for the past 2 years and really listening to those that are on the boots on the ground. And as a result of looking at the data and what the data is telling us, in addition to listening to key stakeholders, we've issued a series of funding opportunities. Again, some of those opportunities have been related to recovery housing, substance use disorder drop-in centers, student loan repayment is one of our initiatives, along with community-based prevention services, harm reduction, integrated health services for substance use disorder and physical health. And we'll, in the near future, we're going to also be issuing another funding opportunity to work with faith-based organizations.
All right, and then we use this same priority list for DDAP as well, or is there a different process you guys use for some of their grant funding?
I'm with DDAP, and I just sort of shared our protocol.
Okay, cool. Madam Secretary, as it was stated earlier, your office is focused on efficiency. Do we track the outcomes associated with these grants?
Can you be more specific? I assume you're talking to this. I'm the Department of Health Secretary. This is the DDAP Secretary. Can you be clear on who you're referring to and what your question is? Thank you.
Yeah. Secretary of Health there. As you stated earlier, your office is focused on efficiency. Do we track the outcomes associated with the grant funding?
So most federal grants require us to do reporting back to them on how we've used the funds and the outcomes for those. So each grant has deliverables as part of those, and so yes, we track the outcomes for individual grants and report back to the federal government on those grants. We say we're going to do X. Have we done X? Have we? And what have we? So yes, they all have reportable outcomes.
All right, appreciate that. Thank you.
Thank the gentleman. Representative Kincaid.
Thank you, Mr. Chairman. Thank you guys for being here today. I have a bunch of questions, so I'm going to try and go fast. So for Secretary of DDAP, I want to talk about peer-based recovery support services. And can you talk about the percentage of total funding allocation that goes to those services?
All right, so I have my cheat sheet in front of me. So right now, for this fiscal year, the budget estimates for recovery is roughly around $28 million. And I can share some of our other line items. For intervention services, we're talking about $22 million, prevention, another $27 million, along with treatment, more than $82 million.
So it's about a 4-to-1 between treatment and peer recovery services. Is that correct?
We have definitely, I will say, we've definitely expanded recovery support services across the Commonwealth, so much so that we're continuing. Many of our efforts, our funding announcements this year allowed for the support of recovery support services. We just last year expanded our department to have a recovery unit. So there is a significant commitment to recovery support services, and we expect to continue to expand them.
Thank you. So specifically with the inability for standalone community-based peer recovery support organizations to bill Medicaid for their services, it would seem that the only true sustainable funding source is for DDAP to continue to fund those efforts each year, while also focusing on unlocking Medicaid eligible dollars for the community organizations. Are you looking to actually try to unlock the Medicaid dollars to be able to support our peer recovery support services?
I think that is definitely a discussion that needs to be had with the Secretary of the Department of Human Services. But what I will say, we've definitely had conversations around ensuring that there's parity when you look at what's available and what we're paying for through DDAP funding, and the ability for Medicaid to reimburse organizations for peer support. We do know right now within Medicaid that mental health peer support services are being reimbursed. And so I know that DHS is looking at this and will make some decisions in the near future.
Thank you. We've had some conversations about xylazine and the proposed cannabis legalization, and I'm wondering if you can talk a little bit about the public health aspect of cannabis legalization as it sort of impacts the exposure to other substances that we're seeing in the illicit market, where people are potentially purchasing marijuana, but getting fentanyl, xylazine, and other things together with what they are actually trying to purchase, and how cannabis legalization could address that.
I'm not sure.
I think what you're asking is, we currently have cannabis use going on in the state. We know people go across the borders. Many of our surrounding states actually have an adult use program, and people are bringing it into the state. And there's also an illicit market as well. And I think, this is one of the governor's agenda items is really, if you bring in legal cannabis to the state, can you reduce the exposure to illicit supplies of the drug on the market? And so that is important. We run the medical marijuana program in the Department of Health, and we spend a lot of time on ensuring that the products are safe, that they're tested, that they are packaged so that they're not appealing to children, that they're not labeled appealing for children. And again, I think there are a lot of things learned from surrounding states on what they've done and what's worked well. And there's a real opportunity, because we'd be the 25th, I think I've lost track, but somewhere around the 25th state, we can learn from all of those to bring in a safe legal market to allow us to be able to make sure that those products are safe.
Thank you. And quickly before my time expires, what is the current balance of the medical marijuana fund?
I'm sorry, I didn't hear your question.
The medical marijuana fund, what's the current balance?
Kristen, do you have that? We don't have it right in front of us. Can we get back to you just because our time is up?
Absolutely. Yep.
Thank you so much.
Thank you, Chairman.
Thank the gentlelady. Representative Guzman.
Thank you, Mr. Chair, and thank you very much for your time this morning, this afternoon. I appreciate it now. I'd like to talk about, we're going to first direct my questions to the Department of Health and then go on to DDAP. Yesterday, I had the misfortune of logging on to Twitter and seeing the head of DOGE talk about cutting over $500 billion of Medicare and Medicaid funding. Dr. Brogan, I'd like for you to, if you can, for this body, what type of impact would that have on poor brown, black, and white folks across all 67 counties if the federal government were to cut over $500 billion in what they call entitlement programs?
Well, most of those entitlement programs are actually in the Department of Human Services, so I'll keep my comments very high level because we have the WIC program in the Department of Health. Again, that program, as I mentioned, is incredibly demonstrated over decades to have really important health impacts for everybody who participates, better pregnancy outcomes, better child outcomes, so really important programs. And again, the Medicaid program falls under the Department of Human Services. As a pediatrician, that I can tell you that that program funds many children in our state for their health care and is essential. So I'll just leave it at high.
So what impact would it have on our healthcare systems here in the Commonwealth?
Yeah, I mean, many of our hospitals rely on Medicare and Medicaid dollars for many of their patients, and it ranges. Some hospitals it's 50%, but some it's much higher. So again, those would have huge impacts on access to care services.
So if it's safe to say that if DOGE is going towards cutting over $500 billion in this critical funding, is it safe to say that some Pennsylvanians will fall through the crack because of this lack of funding?
Yes, we will definitely have uninsured families, and the need for charity care or uninsured care will increase.
What a shame.
Substantially.
What a shame. Madam Secretary, also, I represent a highly diverse immigrant population in the city of Reading, and right now, a lot of folks across the country, and especially in the city of Reading, are a little nervous in regards to a lot of the movements happening at the federal level. I had an individual come up to me worried that she goes to a FQHC, and she's worried that in the very near future, she may not be able to access and have access to health care within our respective cities. So what can we tell the folks in my city and all across the Commonwealth that are looking at this very real reality of not being able to access critical health care services?
Access to health care is essential. If you don't have access to care, you wind up waiting till you're much sicker, and then the outcomes are much worse. So we see this in cancer diagnosis, in heart condition diagnosis. People who don't have ready access wait and wait and wait until they're desperate, and they go to care when it's late and the outcomes are much worse. And it's costly to our healthcare system. We know that prevention is cost-effective care. When you can prevent illness and you can have access to prevention services, you reduce healthcare costs. And that's why if you look at almost every study that looks at reducing healthcare costs, increasing access to primary preventive services has a huge impact on the overall cost of care. And so it's important that people have access every day to primary care and preventive care, so we don't wait till they're so sick that they wind up in our ICUs.
I've never had a doctor ask me for my immigration status. I'd like to move on now to DDAP and ask you all, we were fortunate to have a Super Bowl victory here for our Philadelphia Eagles, and in that occasion, though, my little nephew, about 12 years old, came up to me, and instead of talking to me about the game, he asked me about money lines and the spreads of online gambling. And it led me kind of down a deep rabbit hole because, quite frankly, the prevalence of online gambling has only increased throughout my years. And it's become much easier to not only just sports gamble, but gamble in general, whether it's gambling on sports games, whether it's gambling within video games. It's becoming an epidemic almost. And so I'd like to hear from you all, number one, are you aware of it, which I'm sure you are, but what are some of the initiatives and some of the strategies that you have to help protect Pennsylvania families and/or Pennsylvania kids from falling into the very dark, vicious cycle of gambling addiction?
You're spot on, and we definitely have been tracking it. As you heard me mention a little bit earlier, we do a gambling and gaming report as a result of understanding the magnitude of what's happening. We are expanding our department to address this specific issue. So one of the things that we are going to be able to do with that expansion is to offer additional supports and services, but also continuing to work with our partners around prevention and expanding those prevention services, and really thinking about our messaging and making sure that we're ensuring that there's audience segmentation. And so what one prevention message may be for someone in middle school, that message needs to be different for someone in high school or college. And so we will continue to expand our efforts, and our gambling unit, and I'm turning my body because I'm going to look at Erica once again. That sits with Erica Noko, so I'll let her add a little bit more color and context.
Sure, thank you for that. And there has definitely been an increase in internet gambling that we have noticed. So our team is really taking a look at the current work that we're doing. In that work, we noticed there's a lot more need for case management services, as well as recovery support services for individuals who are gambling. So in addition to that effort to really do a lot more around prevention in multiple different groups that would be going down to younger ages now, so that they understand what the issues are around potential problem gambling, but also looking at a whole variety of populations to include at a collegiate level. Also looking to expand, looking at services for aging adults around gambling as well.
Well, I'd definitely like to see more in that respect, and I thank the gentleman for his time. Thank you.
Thank the gentleman. Representative Mullins.
Thank you, Mr. Chairman. Both Dr. Davis-Jones and Dr. Bogan, thank you for being here. Dr. Bogan, as a parent of an 8 and a 4-year-old, I must say it's nice to see a pediatrician in this setting, and not the one we usually do. But it is, I'm very, I'm filled with hope and optimism regarding the first ever inclusion in a state budget proposal for neurodegenerative research funding. And you and I have been working on this for a number of years, and I'm so glad to see it included. When we first started working on this, not long after losing my father to ALS, I didn't imagine that we would be, we would also be trying to counter and deal with the devastating, misguided, and cruel cuts by this White House for things like NIH funding for these diseases. But that notwithstanding, we must fight the fight here and work to secure this appropriation and make sure that the state has skin in the game when it comes to funding this critical, hope-giving research into these fatal diseases. So it's a $5 million appropriation proposal for neurodegenerative disease research. Just would love if you could expand a little bit on how those funds would be used and why continuing to support this medical research is so important.
Yeah, it's nice to see you and have the opportunity to talk a little bit more about the neurodegenerative research proposed appropriation.
The whole thing's a tongue twister.
We have world-class research institutions in Pennsylvania. We're really blessed with so many of them. I would venture that there isn't a single person in this room that isn't been affected by a neurodegenerative disorder in someone in their family. I have a brother whose wife has early onset Alzheimer's, and the struggles that we all see with neurodegenerative diseases like Parkinson's, ALS, It's really important. So I think we've talked about getting this money out to the academic institutions to do the work and really come up with treatments and cures and perhaps prevention in the long run. And so again, I think this is the work that the General Assembly will have to do. I look forward to working with you to identify paths forward. We've talked about whether this should be early career science work or should this be pilot work, in really innovations, or should this be when it's close to discovery. So where in the spectrum is it best used? And I think there's lots of opportunities and lots of smart people here to help guide us on those discussions. So I look forward to hoping that we see this appropriation fulfilled.
That sounds like a plan. Thank you.
Thank the gentleman. Chairman Gillen.
Thank you very much. Appreciate the distinguished panel and their presentation today. Dr. Bogan, you are a lead agency for emergency medical services in the Commonwealth of Pennsylvania. How would you characterize the state of EMS in the Commonwealth today?
EMS faces a huge number of challenges. We have over 1,000 agencies across the Commonwealth, not all equally distributed, some areas where there's lots and some where they're really sparse. Reimbursement is an enormous challenge. Our EMS agencies are really not well funded for preparedness. So they show up at every house fire, they show up at every automobile accident, and whether or not they actually transport someone determines if they get paid for that readiness. They drive very expensive equipment that is loaded with expensive equipment, and so that's a huge issue of how do we fund that. And then there's workforce challenges as well, and reimbursement rates. So we have been spending a lot of time trying to understand the complexity of these issues and coming up with what we hope, and we really look forward to working with you, because I think that there are real opportunities around reimbursement and readiness and other areas. We're working a lot on training. There have been pretty substantial efforts on the education piece. We've hired a couple of folks specifically to address education in our rural areas as well, to look at our different training institutes and the variation in outcomes. I know in the past we've talked about the test that they have to take. We are exceeding the test pass rates in Pennsylvania compared to the national rates, but I think there's opportunities to make more consistent training opportunities. Our summer camp program was a big success, and that's getting funded again this year to go out and get money out to build a workforce. But there are tons of opportunities, and working together, we have to come up with solutions, because if you call 911, I call 911, we want an ambulance there. We want it timely, we want them well-trained, and we want them to be able to get us and provide those services in our communities. It's not like the 1970s when we started ambulance services in the 60s and 70s. It was a transportation service. Now it's truly an emergency department on wheels. Last year, for the first time, we allowed whole blood products to be given in the field through our EMS advanced teams, and they gave whole blood over 100 times in the field last year and saved lives. And we all want that available, and it's at risk if we don't address the funding and workforce issues.
Thank you. Very surgically, is there something in the governor's budget that specifically you could highlight and say this is going to be a real game changer?
I think there have been some changes. Because of the increased fees that we've been collecting, there has been an accumulation of funds in the MSOF fund, and we are reallocating that over the next couple of years to get out. So we are seeing an increase in MSOF. Again, we're working on our efficiencies to get the money out through our EMS agencies, and I think there's other opportunities in reimbursement in other areas, so I look forward to those discussions.
As far as agency closures, do you see that slowing down, or is that still on your front burner?
We are working with our regional councils. We now meet with them every month. Kristen and I spent about an hour and a half with the regional council leads recently. I think those are discussions to be had, and they are closing. We've had some closures, and I think the reasons vary, but for the ones we just discussed, right? Funding, workforce.
How would you characterize the relationship between the EMS providers and your office, given that there have been some tensions that have existed in the past, and how have you ameliorated some of those concerns?
Yeah, we hired Anthony Martin about a year and a half ago, and one of his main tasks, I think I mentioned last year, was to really rebuild that relationship. And we've done that in a variety of ways. We have set up much more regular meetings with our regional councils and our agencies. We've been out to visit many of them, and we will continue to do that. And we've built a much closer relationship with PESH and the MAC to try to, again, we redid our process of how we're going to roll out new protocols, working much more in line and tandem with those organizations to make sure that they have a voice at the table, and we hear from them because they're the ones out delivering the services, and we want to make sure that they have an active voice. So I would think if you go around the state and ask 2 years ago to now, there have been great improvements in those relationships.
And Anthony Martin was a very wise choice as a Berks County, and may I especially commend you on that. Just very briefly, Representative Causer, Chairman Causer sent a letter to your department on February 14th. Any response publicly on that, or is that something you're still working on?
Yes, that was a very thoughtful letter. Thank you. We are working on our response to that.
Thank you. Thank you, Mr. Chairman.
We thank the gentleman. Chairman Frankel.
Thank you, Chairman, and thank you, Secretaries, for both being here today. I also want to thank both of you for the access that you've provided the members of the Health Committee as we do our work, and we appreciate your availability. I wanted to talk a little bit about, the public health aspects of legalized adult use. As you may know, we've, in the Health Committee, have had 6 hearings last session. We're in the process of drafting legislation for adult use that will prioritize public health. And the fact of the matter is, and I think as you said, what we have now is the Wild Wild West. It's always been there. It will always be there until we find a safe, regulated marketplace as we move forward. But I wanted to talk a little bit about and ask you about the current medical marijuana labs. And Pennsylvania has testing requirements to make sure that medical marijuana product patients are purchasing are safe. In your opinion, does the Department of Health have enough oversight authority to over these products and these laboratories?
So it's very important to be able to ensure that the products for the medical marijuana program are safe because they go to vulnerable populations in need, including older adults and some children with very special healthcare needs. We currently have some oversight of the labs, but some of it is also under judicial review. But I think what we're looking for is to be able to ensure that the products are safe, that the THC levels are not inflated, and that they are not contaminated. So we look forward to continued conversations with you all on what that bill should look like to ensure that we do have the ability to ensure that the products are safe for consumption.
Oh, we appreciate that, and we are moving legislation along those lines, as you well know. Earlier today, you talked a little bit about the private equity issue in the healthcare sector, and clearly it's been a huge problem, not just with hospitals, but also with nursing homes. Due to our most recent regulations, the department now has the ability to review some transactions for nursing home purchases in advance. Can you tell us what you've found and what you've been able to do with that information?
Yeah, so the long-term care regulations did include the allowance of us to be able to get audited financial statements. We built a team with some financial expertise to be able to review those financial statements. And we've begun to receive them both for change of ownership as well as for license renewal. And particularly the way we've used it is we have denied a couple of change of ownership applications from organizations where we can look at how they operate in other places in other states and make sure that we want them to come into the state with good financial backing so that we don't have them purchase a long-term care facility and then close it. So we've used it that way. We're continuing to learn. I would say it is a continuing learning process, right? The team has been together for a short time and really developing the expertise to make sure we're doing it. We've also been talking to other states because the same thing is rolling out in other states. I would say we may be a little ahead of many of those states, but we're continuing those conversations to see what we're all learning and make sure we have the most up-to-date practices. Be happy to check back with you in a couple of months as we continue that process.
I appreciate that. Thank you very much, and thank you, Mr. Chairman.
Chair thanks the gentleman and recognizes Chairman Struzzi.
Thank you, Vice Chair Mullins. Thank you all again for being here today. I think clearly we face a lot of health challenges in this Commonwealth, particularly in the rural areas. So I'm glad to see that there was a lot of discussion about rural health care and EMS as well. I know in my county, I have Indiana Regional Medical Center, and they do a great job providing services and actually creating a network, and I'm sure you're aware, a network of other hospitals that they work together on to try and address some of the issues that you outlined earlier. And unfortunately, we just lost another EMS provider in the southern part of the county, and that further stretches Citizens Ambulance to cover those areas with, again, minimal staff and costs that they simply can't afford. So I think that it really is a crisis that we're facing in rural health care and EMS, and I'm glad that you're aware of it and we're paying attention to it. But I have a specific question for Dr. Jones related to telehealth outpatient licensing. In December, your department created a new telehealth outpatient licensing category that enables out-of-state providers with no physical location in the Commonwealth to get licensed to provide substance abuse disorder services. And it's my understanding that treatment providers in Pennsylvania were opposed to this action due to patient safety concerns. Can you tell me why that continued to move forward despite the opposition from in-state providers?
Yeah, absolutely. The first thing I would say is we are a firm believer that we need to expand access to treatment across the Commonwealth, and virtual health or telehealth is one such option. What I can tell you is that some of those out-of-state entities were already operating here in the state of Pennsylvania. So therefore, we decided to create an opportunity for them to become licensed. They will have to follow all of the standards, all of our regulations that are required to operate SUD treatment services, minus the physical plant regulations. And so with that being said, I probably would also clarify it from the perspective of that this license was not created for out-of-state entities. Okay. It was created for any entity within the state of Pennsylvania to also operate an SUD telehealth license.
Okay, if you do get out-of-state providers, though, how do you address those concerns that patients may be prescribed narcotic medications without the ability to perform drug screenings or monitor for illicit drug use?
That is an agreement that they have to have with another entity in order to be able to do that.
So the out-of-state provider would have to work with someone in-state to provide that?
Absolutely. They would have to be able to it would have to be a collaborative effort. In addition, we're going to continue to monitor those entities. They will still have inspections and records and things like that. So right now, since we've released the licensing alert, we've had inquiries about 11. Mm-hmm. And so far, only one was from an out-of-state entity.
Okay. Okay, and then moving on, there's a lot of discussion about the legalization of recreational marijuana. I think there's a lot of concerns with that, particularly in both of your agencies. And my question, though, we learned earlier this week that the administration is providing $2.5 million to the state police to essentially prepare them to deal with the changes that legalizing recreational marijuana will bring to their departments. And I think that number is probably low as far as the amount of funding needed to transition to that. But my question is, given what you do within your respective agencies, has the governor allocated any funding for your departments, given that you will probably need to hire more staff, have more training to deal with this? Dr. Bogan, you just mentioned the need for testing. Has the governor allocated any additional funding to your departments for recreational marijuana?
Not at this time.
Dr. Bogan?
You know, we have funding for our medical marijuana program, and within that funding, again, the Department of Health's program will, we want to make sure there's a maintenance of a medical marijuana program, because there will be people who won't want to use an adult program, and also the medical program ensures that people have access to a wide variety of products, including tinctures, suppositories, and things like that, that are often only really used by a medical program. So we have funding currently, again, for our work related to medical marijuana.
But not for recreational marijuana.
Well, our work, again, won't really, our work will continue to do the work we're currently doing and we have funding for that. So at this time, there isn't really a need for us to have adult use funding because we have the program that we're running. So I'm not sure why he would want to allocate funding for us at this point. We are having discussions.
I'm just trying to foresee, because, you know, we're talking about the budget. And if we don't allocate the proper amount of funds, those funds have to come from somewhere. I know the state police are proposed to be, this $2.5 million for state police is proposed to come from the profits, the taxes that will be collected from legalization of recreational marijuana. And it just, I think it's important that you all have those discussions with the administration in anticipation of what might come as a burden on your agencies.
So if I could just say something, definitely, you know, if we, for example, see an increase in treatment needs, one of the things that we can do is advocate for expanded use of our existing federal funds to make sure that we're helping all Pennsylvanians with, you know, all kinds of substance use disorders. So we'll continue to advocate.
All right, thank you. I see I've taken advantage of Vice Chair Mullins' time.
I just wanted to, so we also have had discussions about the adult use with the governor's office and continue to do that. And we'll, of course, put together a budget if we see a need. But I think, like right now, this time, there isn't an additional need in the department.
Okay, all right, thank you.
Chair, thanks, gentlemen. And with that, our hearing is concluded. We thank you for your testimony and for your service. And we will return at 1:30 for the Pennsylvania Emergency Management Agency and the Office of State Fire Commissioner. Thank you.